I'm Dr. Ali Atif, oral and maxillofacial surgeon practicing in Lucknow. I have a center named Alpha Aesthetics Clinic in Mahanagar, Lucknow, and I practice in the head and neck region. My core interest is head and neck oncology and a lot of facial aesthetic surgeries, including hair transplants, facelifts, rhinoplasties, otoplasties, cheiloplasties, orthognathic surgeries, and advanced implantology for full mouth rehabilitation. My core interest in oral and maxillofacial oncology has been there for the last few years. I have been practicing head and neck oncology for almost 12 years now. I did my master's in 2017, and since then I've been practicing head and neck cancers, and it has been a very developing journey in which we have been treating almost more than 300 400 patients, and we almost do a cancer case every day in our OPD, and that is how it has been so far.
Thank you, Dr. Ali, for giving your introduction. And now let's begin with the podcast. So, my first question is let's talk from the very beginning. Like for someone watching at home who has never heard the term oral cancer. Okay, so what exactly it is? Where in the mouth and face can it develop? And why is it considered like one of the serious cancer for a person?
Hello, Dr. Basim. First of all, so lovely to catch up with you. And coming back to your question, that anybody who's listening about oral cancer should know that it is something which starts inside the oral cavity. That is why it is called oral cancer. But it tends to spread into distant regions as well. Now, where does it grow? It grows on the tongue, on the lip, on the floor of the mouth, onto the cheek, okay, on various part of the mouth, even the jawbone. So you can find oral cancers developing any of these spaces. Now, what is oral cancer? Now, if you look at cells that you are made up of, in a normal person, these cells, they develop in a normal manner, but in a cancerous patient, they tend to lose that normalcy, and they tend to multiply at a very fast rate, and that is why it becomes like a tumorous growth, and this is not stoppable. You cannot stop this growth, and it tends to travel from your oral cavity into your lymph nodes, and then to your lungs, maybe your bones and distant part, and that is why it is a very dangerous sort of cancers, right? These are very dangerous sorts of cancers. There are a lot of cancers on the body, but oral cancers are particularly very notorious in name, and that is why early diagnosis and awareness about oral cancer is very, very important.
Who is most at risk like of developing oral cancer? We hear like about tobacco, alcohol, betel nut, and
Exactly. Yeah.
HPV as like major risk factors. Can you explain like each one clearly and tell us like which is single biggest driver of oral cancer?
So the biggest risk of developing cancer is amongst the patients who are tobacco consumers, right? Like you would see a lot of chewing tobacco in India. You will see a lot of smokeless tobacco being consumed in African countries. Okay. So the tobacco is one of the carcinogen which causes or triggers the cancer in the oral cavity. Along with tobacco, there are certain confounding factors, like say somebody who's having tobacco is also having alcohol, right? So it is having a synergistic effect. And let's say somebody is not having alcohol, somebody is in a habit of chewing areca nut or betel nut, okay, that also exaggerates certain conditions like oral submucous fibrosis. You will see that somebody who's just simply chewing on areca nut starts to develop a fibrosis around the mouth, so that the mouth opening becomes very little. He is not able to open the mouth, and then this is like a pre-cancerous condition which later develops into cancer. Now, along with it, there are certain viruses also, like human papilloma virus. Sometimes a person who is infected with human papilloma virus also gets triggered into cancer, because we do a lot of biopsies. No? We remove the cancerous lesion and we send it for biopsy, and we find that a lot of human papilloma virus is present. So sometimes it is also viral in origin. But in all the cases, the biggest driver of oral cancer is tobacco use.
So, what are the early warning signs for oral cancer that patient tends to ignore on mistake for something like harmless, like mouth ulcer or tooth problem? Like, how long do patient typically wait before they see a doctor, and why does that delay, matter so much?
So, when we talk about oral cancers, first of all, there should not be a havoc or scare that any ulcer is not oral cancer. There are sometimes, presentation is very atypical presentation. You can say there is an ulcer which has been there in the oral cavity for, say, many, many months altogether. Or the patient has, as I've already told, certain white lesions, or there is fibrosis, mouth opening has become over a period of time very reduced, and patient starts to feel burning sensation throughout the oral cavity. He is eating spicy food, is not able to consume spicy food. There is reduced mouth opening. There is a lump somewhere in the oral cavity or in the neck, which he feels is very hard lump. These are the warning signs that the body is giving you to see a physician or a dentist or a maxillofacial surgeon or a cancer specialist. So nobody would directly go and feel that it's cancer. They will first go to maybe a dentist for an oral ulcer, and a dentist who is trained in oral oncology is the best person to make that early diagnosis. So the thing is, this transition from a simple ulcer to an oral cancer is not a one day thing. It's not like one fine day you will wake up with cancer. No, a body shows pre-cancerous lesions and pre-cancerous conditions. Pre-cancerous lesions like the white plaque, which is very commonly known as leukoplakia. You will see there is a white patch inside the cheek, and it is, you're not able to remove that white patch. It is not like a scrapable white patch. It is a non scrapable white patch. That is a early warning sign for a cancer. It's a pre-cancer lesion. Or you say there is a reduced mouth opening. Again, a very big sign for a developing oral cancer, which might develop into an oral cancer. So I would suggest not to wait for too long. If you have something which stays and which has characteristics which is suspicious, please just go see a doctor, see a dentist.
Let's talk about the jaw tumor specifically. Like, can you explain what a jaw tumor actually is? Where does it grow? Why does it grow? And how it is different from oral cancer of the soft tissues like tongue and cheek?
So now this is a very interesting thing that you have brought about. So you have basically differentiated a cancer, which is a malignant problem, from a benign problem, which is a limiting problem like a tumor. So let's first understand what is a tumor and what is a cancer. A cancer is a malignant growth which needs complete resolution along with neck dissection, removing all the infected lymph nodes, and then followed by reconstruction. A tumor, on the other hand, is a limited growth. It is not cancer. It is at a risk of developing into cancer, but the origin of this problem is derived from certain potential that is there inside or genetically predisposing factors. Like, let's say you have an infected tooth, and you have not taken care of that tooth for too long. It is lying there are high chances it will develop into a cyst. If you are not taking care of that cyst, it can develop into a tumor. Then there are so many tooth derived stem cell oriented tumors. You can say there is ameloblastoma, very common. You can find that there is an, if you look at the skull, there are a lot of times that there are tumors growing within the jaw. Some tumors, they grow in width. So when they grow in width, they expand the jaw. So it is very much visible. It is visible to you. There is a swelling. But there are sometimes certain tumors which grow in length. So they will grow in length. They will grow in a way in which you will see it is growing within. So unless it reaches down to a tooth which becomes loose, or the swelling becomes evident, or you would say there is loosening of teeth, the patient doesn't get to know. So these tumors, when they are actually treated, they are self-limiting. They can be removed with no chances of developing or passing on to adjacent areas. So they are limiting in nature, and that is why one should be very, very vigilant about getting their routine dental checkups in case they find any kind of a lump inside the mouth.
So you talked about ameloblastoma. Like, ameloblastoma is probably the most talked about jaw tumor. So can you specifically explain what an ameloblastoma is? Why it is,
So,
yeah, why it is so
so
concerning, right? Benign, like being benign, and what happens if it is like left untreated for a long time?
So basically, ameloblastoma has a different status in terms of tumors. So when we talk about cancers, it is squamous cell carcinoma, which is very dangerous. When we talk about tumors, ameloblastoma is also something which is a little rare, but a very concerning or disfiguring tumor because it is massive. It is massive. So it is a rare growing tumor. It is a rare, slow growing tumor, and it usually forms in the lower jaw and the back teeth region, okay, where you will usually find your wisdom tooth is impacted or it is not growing. So it triggers into that region of the bone and it keeps on expanding in the internal side, and it tends to kind of resorb or dissolve the bone around it, and it is so massive that it keeps on spreading all the way front, back, sideways. Wherever it finds its way, it keeps on growing. So why it is very concerning, like you mentioned, it has a malignant potential. If not treated on time, it can convert into a cancer. So that is why this particular tumor is something which needs to be diagnosed first. A biopsy is done to first differentiate it from cancer, and then a definite reconstructive treatment plan is made to correct this kind of problem. And unfortunately, because it is a very slow growing tumor, it tends to involve most of the empty spaces in the jaw, and most of the time, if it is diagnosed late, then you have to sacrifice half of the jaw, or sometimes in certain cases the full jaw has to be sacrificed.
I was talking with one of the patient and he was having an ameloblastoma. So actually he told me that he have a bad breath. He has a swelling, he has a bad breath. So at what stage does these symptoms started to appear?
So unlike other problems, this is basically a painless swelling. So unless the patient has pain, usually the patients are very careless about anything that is happening. But once the pain starts, it is showing the early signs of involving the teeth. The teeth tend to become loose, and once the teeth are loose, what happens is there is spaces in between in which there is a lot of food lodgement. And because this is such a massive disease, sometimes there is an infection also added to the tumor. It might have pus, and that is why there is a very bad smell, which is called halitosis. Halitosis also comes into that picture, and it also involves some part of the gums. So gums become red and swollen at times. So that is also where a lot of food lodgement happens. And this is the time where you can actually, you can see that this is the time when usually patients, approach their doctors, which is late. It is a little late to actually reach the doctor, but okay. At this point also, if the patient doesn't ignore the problem, it can be treated.
Can you walk our audience through what actually happens during surgery of our oral cancer? What is removed? How wide does the surgical margin, and how does the surgeon make sure that all the cancer has been taken out?
Now, talking about oral cancers would have a classification which is known as the TNM classification. We will not get into too much of geeky stuff right now, but one should understand that there is a tumor size, number of nodes that it involves. There is also a potential of metastasis. Metastasis means that cancer was in the jaw, but now the cancer has spread to distant lymph nodes. How do we determine that whether a lymph node is involved or not? What is the size of the tumor? How many nodes are involved? So there are certain things that you can palpate the patient. You can actually visualize. If there is a cancer, you will definitely see the borders are indurated. There is hardening around the area which is having cancer. It becomes very hard, not like supple, like the skin is very soft right now. When you have cancer, it becomes fixed, hard. So you palpate that margin. Intraorally, you mean to say if it's inside the mouth, then you palpate inside the mouth. If it shows the lump is outside, it has spread outside, and you see there is a growth outside, you palpate and you take some healthy margins when you are removing it. Let's say there is a small tumor, looks like a small tumor, but we have to take a safe margin of around 2.5 centimeter around this region, at least, so that you know that this is cancer free. The margin that you're taking is cancer free. Imagine if it's just a small little golf ball kind of a diameter, you have to actually remove the circumference of a baseball, ball of a base, like you've seen a tennis ball. So you can imagine the kind of skin that has to be removed. Of course, this is a very ablative surgery. We have to go aggressive, because if in conserving this area, if you want to go just for the cancer margins, then it is definitely going to recur. There is a high chances that there will be a regrowth of cancer. So to keep that patient safe from any recurrence, we tend to make a wider diameter, right? And then this is the primary site. The tumor is the primary problem. But as I've told you, TNM, the nodes, now comes the lymph nodes. So then a neck dissection has to be made. The neck is opened, all the lymph nodes which are infected are removed from various levels. There are various level 1, 2, 3, 4, 5. We remove the lymph nodes. All the fat which might contain the cancer cells are removed. And then we check, we send them to the biopsy to check what level, say whether the lymph node was present in level 5 or not, whether it was present in level 1, 2 or 3, which level. So that on the basis of this, we decide whether a patient would go for radio or chemotherapy or both. How will we treat it? Is this treatable, or what stage? This is basically cancer staging. So can we actually operate this case? Will it offer any kind of help to the patient, or is it non-treatable? All of these things are judged with the help of TNM classification.
So like TNN classification is like most important to help you understand like which.
Yes, actually, the patient has to be given some yardsticks to measure which stage he belongs to. On the basis of that, the future planning of the treatment has also, only the surgery is not important. It is easy to talk about it, but imagine somebody without the jaw. How will he eat the food? How will the healing happen? How much time will he be fed from the nasal tube? Because internally everything is healing. All of this is a part of the rehabilitation that we have to look into, right? So there are a lot of reconstruction options which are based on this. If somebody has to go for radiotherapy, when should we reconstruct? These are all elaborated topics. We can discuss about them one by one.
So now let's move on to the next segment. So this is the question that every patient, and family fears the most. Like if part of my jaw has to be removed, so like what happened next? Will I left without a jaw? Can you reassure our audience like by explaining what jaw reconstruction actually is and what it is possible today?
Absolutely. So in today's time, we are having all the latest equipments. We have 3D printed jaws. Let's say a patient comes in and half of his jaw is gone. Half of his jaw has to be removed. Back in the day, we did not have too many options. But now you can actually reconstruct this area with the help of a bone in your leg, which is known as fibula. Very famous. You can actually harvest that bone, shape it into a form of a jaw-like structure and plate it in this region. You can fix it like the jawbone, and it has its own blood supply. So if the audience want to know what it is, they can search about free fibula graft. So fibula is basically the bone or the leg bone, which is used to recreate the jaw. This is showing very good results in most of my cases, and we have seen that over a period of time you can also place dental implants into this bone. So not only will the jaw is reconstructed, teeth can also be reconstructed on that, and the patient can go back to his normal life like a normal patient.
So you have like covered 2, 3 topics. So are there any other reconstructive option beside free fibula?
Yes. So this is about, let's say, the bone. Sometimes the main problem is around the cheek. So because free fibula and free flaps are sometimes not a very cost effective treatment, and sometimes it is also not possible. In certain patients, you will see that the flap is not of a good quality, or there is some pre-existing condition in which we cannot perform that. Then you can also use localized flap. You can use the nasolabial flap, where you can actually reflect the nasal skin and reconstruct the floor of mouth. You can use the neck muscle to reconstruct the floor of the mouth, right? You can also use chest. There is a muscle called pectoralis major. So there is a flap in which you can actually take muscular flap from the chest, and you can transpose it, and you can create the inner lining of the cheek, or in some cases, of course, you can use it as a full cheek reconstruction. With that, you can use the forehead. There are so many localized options, localized rotational flaps. But now there is time to work on free flaps. We can also use free radial forearm free flap, that can also be utilized for the construction of tongue, because tongue is a very difficult organ to be replaced. How will you replace it? You need a free flap for that. So now you'll see that not only is the patient rehabilitated, half of his tongue, say hemiglossectomy has been done, half of the tongue is removed, even then the patient can speak. Even then he can get back to the same speech that he had. Okay, I would not say it will go back to his normalcy, but almost normal. Sometimes you can't even tell that the patient has undergone a surgery.
Like what is the realistic functional and cosmetic outcome of these patients like after your reconstruction?
So after any kind of reconstruction, the problem happens that there is some kind of tightening of that area, because in many cases the patient has to undergo radiation. In many cases the patient has to undergo chemotherapy, which shrinks the tissue. There are scar formation. There are sometimes some other, secondary problems in terms of healing. So cosmetically, I have seen when the patient is done with the rehabilitative surgeries, we tend to also provide them with certain lasers which actually correct the scar formation. We give them certain treatments which also help them in the cosmesis, or you can say they are able to look normal as we can make them. Okay. So we correct the asymmetry in a way in which you cannot even say that the patient has undergone a massive surgery, because now we have digital models through which we reconstruct the whole jaw, and we make the whole, like, this is a 3D constructed, skull. You can actually print a patient's skull and you can match the contralateral side, and you can actually create a very symmetrical looking results which look very cosmetic.
Just one question also. Like, how long is the surgery for a major jaw resection and reconstruction, and what does the patient experience in days and weeks immediately after the operation in terms of pain, swelling, fitting tubes, and care? Like, can you please explain that?
So I will just break it down into very simple: pre-operative, intraoperative, and post-operative. As in before the surgery, during the surgery, after the surgery. So there's a transition of the patient. Firstly, when the patient is about to go for surgery, there are certain medications. He's been told to take certain medicines. He's also told to keep the area clean, use certain mouthwashes, certain ointments. Okay. Then during the surgery, depends on what kind of reconstructive option you're choosing, right? Even if you do a cancer operation of the oral cavity, usually takes about roughly about 2 to 2.5 hours to remove the primary tumor or the cancerous growth along with neck dissection. And another, you can say 1 hour or 2 hour if you're using a localized flap. A local flap meaning, let's say, a rotational flap from the chest or from the nose, nasal area, cheek area. If you're using a localized flap, it might take another 1 or 2 hours. So in total, a reconstruction with primary resection with reconstruction of through a local flap would take roughly 3 to 4 hours. But things change when you are using a free flap, because when we are using a free flap with bone reconstruction, it might take as long as 7 to 8 hours. It might take even more if it is a very complex case. But free flap reconstruction with soft tissue, like a radial free flap, radial forearm free flap, then it might take lesser time, maybe like say 5 to 6 hours. Because when you're doing a free flap, you have to basically anastomose two different vessels, the vessel of, say, the forearm with the vessels of the oral cavity. You have to actually tie them together so that the blood circulation is established. Okay, so these surgeries can take longer. Now this is about the during the surgery. This is the time that is going to take place. Now what happens immediately after the surgery? The person is under anesthesia. For the first day, the patient is kept in ICU care with the nasal tube, and sometimes the tracheostomy is also done, so that there is no fear of having any kind of airway obstruction. Okay, there might be sometime there is mild oozing, so we do a tracheostomy beforehand so that the patient is completely comfortable during his post operative phase. One day or one night, we try to keep the patient in ICU under complete, and say, where everything can be monitored in a complete medical monitoring system. And from the second day, third day, we make the patient walk. If the patient is there, we make them walk a little. We remove the catheters. We make them go to the washroom themselves so that there is a nice circulation happening. Of course, this is a big surgery, but then we tend to rehabilitate the patient faster. The patient is kept on a nasal tube because everything inside the mouth is being reconstructed. We don't want any food to contaminate the flap. So everything is fed to the nasal tube. It might sound that the nasal tube is painful, but patients become very, very comfortable with it over a period of time. They're taught beforehand only how to feed. The patient also knows what to take, what not to take. They are instructed beforehand. So until this particular area is healed, it takes about 7 to 10 days. We remove the sutures, the healing is achieved. Then we remove the nasal tube and we allow the patient to eat from the oral cavity, just something which is a semi-solid or a liquid which they can eat. And once the patient is completely healed over a period of 21 days, the patient is good enough to go in for further checkups. By this time, the final biopsy and other important investigations are with us. We already know what kind of a staging he belongs to and what kind of further treatment, radiotherapy, chemotherapy is required, and the patient is sorted. So this whole journey will take some time. Like, the important phase is the first week. After the first week, patient is sorted. The initial 72 hours are very crucial. After a period of 1 week, the patient usually goes back home. I send patient on the third day itself. We discharge the patient on the third day. After 72 hours, the patient is sometimes recalled after a period of 1 month just for a checkup. Then after the radiotherapy, chemotherapy, we look in for further rehabilitation in case the patient needs the teeth, or he needs some correction, or there are some cosmetic concerns. We correct all of those.
What is the single most effective thing the person can do to dramatically reduce the risk of developing oral cancer? And why is regular oral examination so underused as a prevention tool?
Primarily, the single best thing is to actually have a good balanced lifestyle, devoid of any deteriorating habits like tobacco, alcohol, or any substance abuse. Also, safer sex practices is also important, because now you know that there is also an involvement of human papilloma virus. Okay, the HPV is also playing a role in this whole dimension. Plus, imagine somebody having comorbidities like diabetes, hypertension, or hyperthyroidism or other stuff, along with some bad habits leading to cancer. So it makes things very typical in terms of operating such cases. How simple it is to take healthy foods, taking a lot of good green vegetables which have high amount of lycopenes, high amount of antioxidants, and high protein diets as well. A simple routine dental checkup can also prevent many problems. Let's say if somebody is a user, and after seeing this podcast stops taking tobacco, now what he should do? He should do all of the above that I mentioned. Plus, he should actually route all his further journey in sync with the nearest dental clinic which works for oral oncology. Because in that case, you are going to detect it much better and much faster than any of the other specialties, because they are the primary people who are working around the oral cavity, and they are the most specialized individuals to detect cancer on an early stage or a precancerous lesion or condition.
What excites you most, like, about future of oral cancer and jaw tumor treatment, whether it is like robotic surgery, targeted biological therapies, better reconstructive material, or artificial intelligence, in surgical planning?
Actually, I'm glad that we are moving towards an era where things have been developing over, every other day you find some new technology being developed. And of course, the role of robotics has been phenomenal ever since robotics was introduced. I am looking forward to certain preventional vaccines that are also there. You will see that there are a lot of HPV vaccines also coming in. There are also, research going on oral cancer vaccinations. But most of all, I see the future is in terms of technicalities. We have stem cells which are used to, generate healthy tissues, healthier scaffolds. Rather than going for very ablative surgeries, we can actually minimize the risk of any kind of morbidity caused by the surgery itself. So we have targeted therapies as well, like you mentioned. So the future remains in the hands of, all the technical things that are developing with the help of AI, with the help of research, and with the help of the funding that all the governments across the world, they are putting into this kind of cancers, which are merely, very, very debilitating in terms of quality of life. Because, everything is, at the end of the day, a man is doing everything for food. Oral cavity is the cavity which will help you ingest that food, and everything goes wrong here. The whole systemic health of the patient deteriorates. So I'm looking at a brighter future. I'm looking at brighter developments in the field of oral reconstruction options. And yes, you're as you said, there are many targeted therapies, and there are more evolving therapies that are developing, and the future looks bright.
So my last question in respect to the patients living in Africa or Middle East, where oral cancer and jaw tumor surgery is either not available or not affordable. So is traveling to India for this treatment a realistic option? And what should they look for choosing a center?
So, the main problem amongst the Middle Eastern population and African countries is that there is lack of expertise. And even though there are very good doctors that I know who reside in these countries, you can say there are sometimes inavailability of infrastructure, or you can say the costings are so enormous that cannot be, it is not something which is accessible to a general person. In that scenario, in that case scenario, you can say that our country, India, has become a capital for a lot of such patients who travel very easily, and everything is planned beforehand for them, right from their accommodation to their travel, from the airport pickups to their hotel. Everything is planned, even their diet, meals, and their itinerary. Everything is taken care by team holistically, and the transition is very smooth from their parent country to the country that they are being operated, or the city that we are operating in. And the point that is most crucial is that here in India, we have some absolutely fantastic doctors, and the infrastructure has been, pulled in. You'll see most of the cancer specialists around the world are mostly, you'll find them, there are a lot of Indians in that scenario. So we have a very nice team of doctors, and we have treated so many patients from Africa. We, in fact, have such a strong referral system in which we have already treated so many patients from Africa and Middle East. So I think this is no more a problem in 2026 as we speak. This is not a problem for anybody to travel from Africa or Middle East to India and get themselves treated. Even in terms of monetary, or in terms of travel hitches, it is pretty simple and pretty affordable.
All right. Thank you, Dr. Ali, for your time and for giving the details about oral cancer and jaw tumor surgeries. And it was a pleasure hosting you and looking forward for more sessions in future.
My pleasure, Dr. Basim. It was truly very, very jovial and nice to get in touch with you. And these were some very nice questions, very close to my heart, because I've been working in the field for quite some time. And in case any of you want to know more, they can actually connect with us. And we operate in Lucknow, in Mahanagar, and my clinic's center name is Alpha Aesthetics Clinic, and we'll be happy to guide you further.
All right. Thank
Thank
you
you so
once
much.
again and have a nice day, sir.
Thank you.